what we have. Alright. I'm gonna feel this. Okay. And my hair is down. It needs to be up. Okay, we're gonna start this over. In 1 second.
Okay, so giving injectable medications, obviously you start with the same sort of thought process that you would with whenever you're giving any type of medication. So you want to check the MAR. You want to make sure that you're functioning off of orders that are complete, accurate, and appropriate. So you want to be asking yourself, is it complete? Has the physician signed this off? Is there proper transcribing? Is there any holes that I'm missing that could get me in trouble for administering this? Is it clear? Do I understand what they're trying to tell me to do here? And is it appropriate? So this, of course, is a lot of, this is where the clinical judgment kind of comes into play. So you're looking at the medication that you're being ordered to administer, and you're trying to think to yourself, is there some sort of reason that I can see that the patient should be on this medication? And then, of course, you want to be checking allergies. We want to make sure that our patient isn't allergic to anything or any components of the medication that we're giving them, because obviously allergies can be severe, even fatal. So we want to make sure that we're not giving someone a substance that they would negatively react to physiologically. And then, of course, always you want to keep the 8 medication rights in mind. So right patient, right route, right dose, right medication, right time, right frequency, right documentation, right reason, and right to refuse. You want to be taking into consideration the patient's body build. So you would think about things like their muscle mass, their size, like how much subcutaneous tissue can you see, their height, their weight, and also just into keeping into consideration, like, does the body that I'm seeing look like they can withstand the type of, or the amount of medication that I'm ordered to inject into them. In terms of actually carrying out the injection, so there's sort of differences between the two. So for subcutaneous, obviously we use the smaller of the 2 needles because you're going in a sort of a, what is the right term? A more superficial sort of degree. So you don't want to be kind of like sliding this huge thick needle right underneath somebody's skin. That would probably not be very comfortable. And you would use the shorter needle, obviously, because you're not going as deep as you would in an intramuscular injection. So in terms of the actual numbers, usually we use the smaller vials because we don't tend to need to inject as much volume of the medication subcutaneously because the area is so well vascularized that it can be spread so easily, so you don't need the same amount of volume. So we tend to use syringes of about 1 to 3 milliliters. And we give, and it's usually in terms of gauges, it's 0.5 millimeters or 25 gauge. I don't know if I'm saying that right. We're skipping over it. Just know that subcutaneously, you tend to use smaller, thinner, shorter needles with smaller syringes. Okay? Okay. Intramuscular injections. We do the opposite. So we use larger syringes because you can inject sort of larger amounts into the muscle. People tend to be able to withstand that easier. So what it could be like a 2 to 3 mil. I think the max that you can withstand is like 5 milliliters. I don't know. It was in my textbook, but I'm pretty sure it's like max would be 5 milliliters. Would seem. But you can inject more into a muscle. That's the point that I'm trying to make. So we use thicker needles because we're going in deeper, and that's what we do, okay? Because you're going deep into the body, so you want to get all the way in there. You don't want to use this thin little needle. That wouldn't do the job. What was that? I don't know. I'm back because I need to tell you where we tend to do this. So, injections. When we're going to give an injection, we want to be looking at the area of the body that we are thinking of injecting into. We want to be looking for any sort of signs of injury, any bruising, any cuts, any swelling, any redness, any pain, any tenderness. All of those things, it's kind of a mixture of objective versus subjective data collection. So we would be looking with our eyes as well as asking the patient. In terms of areas that we tend to use intramuscularly, I've only ever given one I haven't given one. I've only ever seen my colleagues and classmates give one into the deltoid, and I've only ever received one into the deltoid. How do we find the deltoid? Well, you could probably just touch it, but landmarking is important. So how do we do that? We find the clavicle. Do you see my clavicle? There it is. And we move over to the acromion, and then we move 1 to 2 fingers down, and then right in the middle, we 90 degrees, stick it in there. Stick it in there. And then subcutaneous, you use parts of the body that have more sort of fat and subcutaneous tissue. Like I said earlier, I tend to use on the tummy near the abdomen, but you can use the back of the arm, and you just look for areas of the body that you can see that has a good and adequate amount of subcutaneous tissue, and you're good to go. And again, keeping in mind that we don't want to be looking, or we don't want to be injecting into signs where you can see that there's been a numerous amount of injections, because there can be sort of scar tissue formed underneath of there, which could interfere with the ability of the medication to actually properly sort of perfuse and get into the body. Okay, honestly, let's just keep it real. Okay, Steve, I'm really sorry that this is so horrible, but you didn't want it to be as long as the other one, so this is it. Okay, so we're gonna go, okay, pretend this is closed. We're preparing the injections. What do we start with? We start, obviously, we've checked the MAR, we know what we're supposed to be doing. Let's say, I would do this with the MAR clearly visible in front of me, just so I can quadruple bajillion check as I'm doing this. So let's start with preparing the IM. So we use larger syringes. So for this one, it says 3 milliliters, and we know that we're giving a 1 milliliter, but I only have a 1 mil or a 3 mil in my, in my belongings? I don't know. And I need to use the 1 mil for the subcutaneous because that's the smaller injection, so I need to use the smaller syringe for smaller injections. So I can't use a 1 mil. I would probably try to use a 1 mil because it's the exact amount that I'm trying to inject, but we're working with what we have, people. So obviously you would open. So I'm taking out my syringe. You can't see. It says 3 milliliters. And this is my needle. I'm putting this in the garbage because it's garbage. And so let's just say that this vial is the proper medication. So for what are we giving IM in this situation? I said previously, we're giving a milliliter of Haldol intramuscularly. So let's say that this says Haldol, and I would be checking for the expiry date, making sure that it hasn't expired, and it hasn't. Surprise. This is normal. Okay, this is Haldol, hasn't expired, we're good to go. So you open. This is very hard to open, so ta-da, it's open. And what would I do? I would open an alcohol thing, and I'm wiping the top of the thing because I would want to make sure that I get off any lingering bacteria that could still be there. And I'm going to let that dry while I assemble my actual needle. So this has a safety hub on it, so you're good. So you just put it on and you twist it till it feels secure, and you pull back the lure lock. I don't know if that's a lure lock. It's something lock, and it's a safety precaution on needles. Pretty sure it might be lure. Okay, so we're giving 1 mil, right? Right. So I was taught in the modules that you have to pull 1 mil and then inject 1 mil of air into the vial, and it makes sense in my brain because we don't want to create a vacuum. That would cause the vial to implode. So 1 mil of air that I put in there, and it's dry and clean, so I'm putting it in and injecting the 1 mil of air. Now I'm tilting it upside down and pulling back until I see that the right amount of medication. Then you want to look for the top of the thing. You can't see, but I'm using I'm using the top line and not the bottom or middle. I'm using the right line, okay, people? And out we come. And there's bubbles, so I'm flicking. Flick the bubbles. There we go. And you're supposed to do this trick where you don't use your hands, but I'm horrible at that, so I've put it on locked. And let's say that I had a good label and I taped it on, and that's done. Now we're moving to subcutaneous. Okay, so again, subcutaneous. What's our order? 5,000 units of heparin. So we're going to check the thing. You're supposed to open an ampule, but I'm afraid of breaking glass, so I'm not going to do that. But obviously you would break, and if you're using an ampule, you have to use a filter needle so you don't inject your patient with glass shards. Okay, so let's say that this is now Haldol, so we're good, and we're checking for expiration, hasn't expired, we're good to go. Again, same steps. You wipe with your alcohol thing, make sure there's no bacteria, let it dry, open your package. Again, using the smaller syringes for smaller doses of medication. So since we're giving 5,000 units, we would want to use the 1 mil. And you pulled it on like this. It's very similar, okay? You've seen. It's dry. It's dry. Do the same thing. I don't know if this is necessary, but I don't see a problem with it. Same amount of volume that you want of medication, pull back with air. And go. Boop, boop, boop. Tilt it up. Draw it back down to the proper amount that you need. Maybe a little bit over because there's an air bubble. And you pull down. Try and flick the air bubble out. If you can't get the air bubble out, maybe squeeze it until the air comes out. Good. And look at that. Perfect. 5,000 units. Again, use the one hand trick. I'm horrible at it. There you go. Label, set aside. You're good to go. I have it all prepared, and you just watched me prepare that. So how do I actually go about doing it? Well, first, hand hygiene. This isn't hospital grade hand hygiene, but it's as good as I can do in my bedroom, okay? So, but obviously you do adequate hand hygiene. Put on a pair of clean gloves. That I do have here. I think these are sterile, so maybe that's unnecessary, but gloves nonetheless. Like, this is a good step that I'm doing. Obviously, I'd be doing this way more professionally, okay? I just find it kind of weird to be filming myself inject into a foamed ice in my bedroom. Alcohol wipe. Why are we doing this? Because we're cleaning the skin. And why are we cleaning the skin? Because we want to remove the normal flora of the skin before we inject, because if we don't, then we introduce displacement of the normal flora into the vascular system, and that can cause infection. So, I've cleaned it, okay? I've cleaned the dice. It's clean, and I'm gonna let it dry. It's dry now, so what do? Well, let's say that this is an intramuscular injection. I've landmarked, I've found my muscle, giddy up, I'm ready to go. So, I have my thing. You take off the safety hub, you pull this off, you turn this around in your hand, you stabilize the patient. I hope you can see this. And then you just go in at a 90 degree, like you're shooting a dart. And you push it in. Hold. Do not move your hand like I'm doing. Okay, this swab is not wanting to come off. Okay, I wouldn't have taken that long. Remove and press. Obviously, this would happen more smoothly, but that is the dice, and it's not an actual human body. Okay, there's that. So dispose of everything like you're supposed to. So into the right receptacles, right bins, okay? Put this into the sharp bin. Put this into maybe biohazardous waste, potentially just the garbage. If it has blood, make a clinical judgment, okay? Just use your mind. So, subcutaneous injections. Let's say that this is the tummy. So, what would I do? First step. Obviously, we're functioning under the idea that I have all of my stuff in a sort of proper format, maybe on a little bedside table that the hospitals have. All prepared. So I'm clean. And now it's clean. I'm going to let dry. While it's drying, I'm going to get this ready. So subcutaneous. It's dried. It's clean. It's good to go. Now I'm taking off this lid. I have it in my hand and I'm pinching. I'm trying to pinch. This is a hard dice. Okay. So I'm pinching, all right? So let's say you pinch really good. That's how I usually do it. I pinch really good so that I have a sort of a nice hump. Is that the right word? A nice bump of subcutaneous tissue that I'm pinching up. And I tend to go in at 90-degree angles if I'm pinching well, but they say you're supposed to go in at 45. I don't know. Just do what feels right. Okay, and in at 45-degree angles we go. And we're in. And we're injecting. This is good. This is going well. And we're taking out and pressing. Okay, we're pressing because we're stopping bleeding. And again, dispose proper containers, sharps, garbage / biohazardous waste depending on the patient. Know what's in their blood, people. They have a blood infection, maybe don't put it in the garbage. And poof, the injection is done. You've completed it. What do you do now? Dun, da, da, da. Documentation. So you document how much you gave, who'd you give it to, where'd you give it, what route did you give it. You just sort of document everything that you did, okay? You document everything that you did, and hopefully you went in to check on your patient an adequate amount of time later to see if they're responding well to the medication. That would be a key thing to include as well. And you just document and you make sure that you sign the MAR, triple, double, quadruple check that you sign the MAR so that people know that you give it, so people don't give it again. Just know how to document people, okay? It's important and it's one of the main things that we have to be able to do, really. So do it. Do it well and do it right. Same things. Those are synonyms. Okay.